living tissue. It is a part of the body skeleton which supports the body. It is tough, it is elastic, it is hard structure of the animal body. It provides an attachment or site for the attachment of tendons, muscles, marrow of the development, protects the vital organ and serves as a storage for the minerals. Now, how are they classified? Basically, they are classified based on the shape, whether they are long bones, they are short bones, they are flat bones, they are irregular bones, they are pneumatic bones with pneumatic spaces, which is basically present in the skull bones, where there is resonance of voice and making the skull much more lighter. They may be sesamoid bone. Okay? And according to development, they may be classified as intramembranous bone, or they may be endochondral bones or sutural bones. So what are intramembranous bone? You've already studied this in your general histology, but just a quick recap. The intramembranous ossification is a process during the fetal development, begins at the second month of gestation. So what do you see here? An ossification center appears in the fibrous connective tissue membrane, and selectively centrally located mesenchymal cells, they cluster and differentiate into osteoblasts, forming a basic ossification center. And then you have the secretion of the bone matrix within the fibrous membrane. The osteoblasts begin to secrete osteoid, which is mineralized within a few days. Now, these cells which have secreted the osteoid matrix, they get embedded with them and they are going to form the osteocytes. Then you have the bone and the bone and the periosteum. Accumulating osteoid is laid down between the embryonic blood vessels, which form a random network. And this results in a network of trabeculae. So you can see the trabecular pattern. The vascularized mesenchyme condenses on the external surface of the bone and becomes the periosteum. So whatever is the condensation of the vascular mesenchyme around it, that is what is going to form the periosteum. The bone collar of compact bone forms and red marrow spaces start appearing. So you have the spongy bone consisting of distinct trabeculae and the vascular tissue, which is basically the red bone marrow. So if you see, there is formation of bone matrix within the fibrous membrane, there is formation of woven bone first, then there is oppositional growth mechanism, formation of compact bone plate, formation of the osteon, and then the bone is completely formed. The second type of bone, how it is formed, is by the endochondral ossification. Now this begins again in the second month of development. It is basically the hyaline cartilage, the bone which the hyaline cartilage further calcifies and forms the endochondral ossification. You can see here the stages of formation of bone collar around the hyaline cartilage model, and then you have the cavitation which happens, you have invasion of internal cavities, periosteal bar and spongy bone formation, and then finally you have the secondary ossification centers which can start developing, and you have the complete bone formation which is there. So formation of bone collar, cavitation of the hyaline cartilage, invasion of internal cavities by periosteal bud and spongy bone formation, which will lead to formation of medullary cavity inside. There's appearance of secondary ossification centers in the epiphysis, and then finally you get the ossification of the epiphysis with the hyaline cartilage remaining only at the epiphyseal plate. So only at the epiphyseal plate you have the hyaline cartilage, whereas in the according to the histological appearance, they are basically mature bone or immature. So mature bone is basically classified into two, that is compact bone and the cancellous bone. So this is how you will see the compact bone and the cancellous bone into the other. Now what are these compact or cancellous bone? They are having a system which is called as the Haversian system or the osteon. They have the osteocytes, they have the central canal, they have the perforating lacunae, they have the bone matrix, and they have the canaliculus. So this compact cortical bone which is present, it consists of packed osteons, and these osteons are called as the osteons. They are basically the Haversian canal which is surrounded by the concentric lamellae of the matrix. And between the rings of these Haversian canal, the circumferential lamellae, you are having the osteocytes which are placed in the lacunae. So you have small channels which radiated from the lacunae to the osteonic canal, through which passes the hard matrix. Then you have in the compact bone, the systems are packed tightly together. That's what is called as compact, what appears to be a very compact mass, because they are very tightly connected to each other. But it's the osteocytes which, along with the canaliculus, which help in building a contact with the other cells. The other is cancellous bone. Now cancellous bone, as you know, it is a spongy bone. All of us know sponge. bone it is lighter, it is less thin than the compact bone. Consists of the trabecular bone, which is having the irregular cavities. It's consisting of the red bone marrow. Now here you can see the canals which are present. They are basically connected by the different Havosian system here. Now this is the cancellous bone. You can see that they're basically the trabecular pattern and the maximum strength which is present here. It appears that the trabeculae are arranged in a haphazard pattern, but they are organized to provide the maximum strength. Similarly, to support a building. So they provide maximum strength. The trabecular bone, spongy bone follow the lines of stress. They can realign. You should remember microscopically there are three lamellae, circumferential lamellae which is there at the end. We have concentric lamellae which are surrounding the Havosian system, and in between the Havosian system you are having the interstitial lamellae. The woven bone which is there, that is immature bone, it is a first form bone, it is a disorganized structure with high proportion of osteocytes seen in young and healing injuries. And the woven bone is weaker because it is non-calcified. A small number of randomly oriented collagen fibers can be seen quickly. It is replaced by the lamellar bone, which is highly organized in concentric sheets with low proportion of osteocytes. And the lamellar bone which forms from there is stronger and is filled with many collagen fibers parallel to other fibers in the same layer. So you have this woven bone which is present, which may quickly break down because the fiber runs in opposite direction, alternating layers much like a plywood, and assists the bone's ability to resist the torsion forces. There are some differences between the immature and the mature bone. We should know the immature bone, the woven bone, the osteocytes are large, they are rounded, they are irregularly spaced, the collagen fibers are randomly oriented, they have variable collagen fiber diameter and the H&E staining. There's a rapid matrix mineralization, low mineral density, high water content, rapid turnover rate of the can be seen here. Whereas in the adult bone or the lamellar bone, you can see there's a smaller flattened osteocyte, they're regularly placed, they have a figure which is plywood orientation which confers the strength. They have regular collagen fiber diameter and they have delayed matrix mineralization. They have high mineral density and low water content. They form slowly and only part is removed by the osteoclast. They have a slow turnover. Coming to the composition of bone, which remains similar, 67% inorganic, 33% organic. You have the hydroxypyrid crystals in the organic component, whereas in organic component, you have 28% of collagen type 1 and 5% of non-collagenous proteins. So organic matrix, basically you have collagen type 1, traces of type 3, type 4, mostly intrinsic fibers, molecular structure. Then you have non-collagenous proteins. Basically, you have osteodectine, osteocalcin, bone morphogenetic proteins, bone sialoproteins, proteoglycans. These are all the structures which are present. With that, we come to the alveolar bone. Now, what is alveolar bone? It is that part of the bone which is present in which the tooth is basically hovering there. So, the alveolar processes, they basically develop near the end of the second month of fetal life. The mandible and maxilla form a groove that is open toward the surface of the oral cavity. As the tooth germ starts to develop, the bony septa form gradually, and the alveolar processes will only start developing strictly after the eruption of the tooth. Therefore, when you see some individuals who do not have eruption of the tooth, they have congenitally missing tooth, the alveolar processes are not developed. In the same way, when the child is an infant, you see that the tooth has not come, you will not see the alveolar processes which are there. They are all formative stage. And when there is extraction of the tooth, there is loss of the alveolar processes because they get built up with the tooth. So the alveolar process is that bony portion of the maxilla and the mandible that forms and supports the sockets of the tooth. So they basically sockets which are holding the tooth within them. The alveolar socket is the cavity within the alveolar processes in which the root of the tooth is held by the periodontal ligament. So it are the ligament fibers which help in the anchorage, and the bone that divides one socket from another is called as the interdental septum. When multi-rooted teeth are present, the bone is called as the interradicular septum. So you have interdental septum, your interradicular septum which is present within the alveolar bone. And the alveolar processes include the cortical plate, the alveolar crest, the trabecular bone, and the alveolar bone proper. So alveolar bone proper, supporting alveolar bone consisting of spongy bone. Spongy bone has type 1 and type 2, and then you have the cortical bone. So how are the alveolar processes? They have an external plate of cortical bone where you have Haversian bone, compacted bone laminae. You have inner socket wall of alveolar bone proper, which is thin, compact bone with perforations, and you have the cancellous bone. So this is how you can see there's an outer cortical bone structure. The cortical plate is composed of lingual and facial plates of compact bone. It is dense in nature. It provides strength and protection and acts as the attachment of skeletal muscle. The mandibular cortical plate is more dense than the maxilla cortical plate and has fewer perforations for the passage of nerves and blood vessels. The cortical plates are least in the maxillary region and the highest are seen in the molar region of the mandibular bone. These are very important to remember as far as your patient is concerned. Then you have something which is called as alveolar crest. The alveolar crest is the highest point of the alveolar ridge and joins the facial and the lingual cortical plates. And the alveolar crest is found 1.5 to 2 mm below the cemento enamel junction. Then the trabecular bone or the spongy bone lies within the central portion of the alveolar processes and it is less dense. When you see this on the X-ray, trabecular bone appears as a web-like appearance. You can see there's interlacing strands and you can see this actually appearing like a web-like appearance. A spongy bone is also called a spongiosa and basically two types, type 1, type 2. Type 1 contains trabeculae which are regularly arranged in a ladder-like arrangement, whereas type 2 contains trabeculae in an irregular arrangement. So type 1 is like a ladder basically, and type 1 is more seen in the mandibular alveolar bone, and type 2, which are basically irregular arrangement of trabeculae, are seen more in the maxillary alveolar bone. So the alveolar bone proper is a thin layer of compact bone that is specialized continuation of the cortical plate and forms a tooth socket. And there is something which is called as a lamina dura. It is a horseshoe-shaped white line on the dental radiogram that directly corresponds to that of the alveolar bone. So the compact or dense bone that lines the tooth, it contains either perforating fibers from the periodontal ligament or just the compact bone. The sharpest fibers embedded into the alveolar bone proper. Now where these sharpest fibers are embedded, these are called as the bundle bone. Present at right angles or oblique to the surface of the alveolar bone and along the root surface. So what are bundle bone? Because alveolar process is regularly penetrated by collagen fiber bundles, it is called as the bundle bone, and X-ray on X-ray the same thing you can see as a lamina dura. It is perforated by many foramina and transmit nerves and vessels which are making it more like a cribriform type of a bone. The lining of the alveolus is fairly smooth in the young but rougher in the adults. So the bundle bone which is there is actually one more part of the alveolar bone, that is laminated bone, where there is normal lamellar structure of the bone and the Haversian system. Then you have supporting compact bone that we have talked about, where you have Haversian system, Walkman's canal are present. And what is the function of this alveolar bone? It houses the roots, the teeth, it anchors the tooth, it helps in the establishment of better occlusion. There is even distribution of the occlusion forces. It supplies vessels to the periodontal ligament. It also houses and protects the developing permanent tooth. It organizes eruption of decimals and permanent teeth. The cells which are present are basically osteoblasts, osteocytes, osteoclasts, and the Lamellae cells. So what are osteoblasts? We know blasts are forming cells, and because they are forming bone, they are called as osteoblasts. They are mononucleated cells that is responsible for the bone formation. Osteoblasts basically produce osteoid, which is mainly composed of type 1 collagen. Osteoblasts are responsible for mineralization of the osteoid matrix. They are basically derived from osteoprogenitor cells of the mesenchymal origin. The periosteum also serves as an important reservoir for osteoblasts, particularly during childhood growth after scheduled fracture or bone-forming tumors develop. Osteoblasts, they appear basophilic. Why do they appear basophilic? Because they have abundance of rough endoplasmic reticulum. Cells contact each other by adherens and gap junctions. They contain actin, myosin, cytoskeletal proteins, maintain cell shape, attachment, and motility. So how do they form? They basically form from the undifferentiated pluripotential stromal stem cells, which lead to in the presence of bone morphogenetic proteins and growth factors, the inducible osteoprogenitor cells become determined, they become differentiated, and systemic and bone-derived growth factor lead to the formation of the osteoblast. What is the function of osteoblast? Formation of new bone by synthesis of various proteins and polysaccharides, regulation of bone remodeling, regulation of mineral metabolism, and mineralization of the osteoid. Now, You also have small amounts of collagen, osteonectin, osteochondrin. All the structures are basically present. And regulation of osteoblastic activity, there is a role of growth hormone, there is a role of vitamin D, growth hormones, insulin, bone morphogenetic proteins. All these different factors play a role. Like insulin stimulates bone formation and mineralization, whereas growth hormone is used for attaining the normal bone mass. Coming to the next, that is your osteocytes. Once your osteoblasts form, they get embedded within the matrix, and these are called as the osteocytes. Now we cannot see basically the canalicular of the osteocytes in the decalcified section here. Why? Because when you decalcify, the bone which is present in between the canaliculi, they get decalcified, they mineralize, mineral ions are removed. So the cell basically collapses, and when it collapses, the canaliculi which are present, the cytoplasmic extensions, because the lacunae are lost, and therefore they is not seen very clearly. So how are they? They basically osteocytes are star shaped, they form a network, they exchange nutrients and waste, and they are present in the lacuna. Now these osteocytes, they are actively involved in routine turnover of bone matrix through various mechanosensory mechanisms. They destroy the bone through rapid transient mechanism. So even these can destroy the bone, and this mechanism is called as the osteocytic osteolysis. The osteoblasts and osteocytes develop in mesenchyme. Their hydroxyapatite, calcium carbonate, and calcium phosphate is deposited around the cell. Now the last cell is the osteoclast. They are derived from the Greek words for bone and broken. Osteoclast means to break something. They are bone resorbing cells. Osteoclasts basically form from the fusion of the cells of the monocyte, macrophage, cell line. Now these osteoclasts which are there, they may have physiological giant cells. They have ruffle border. If you look here, these cells basically are having a ruffle border. They are not smooth, they have a brush border, and you can see the morphologic characteristic of osteoclast, that is actively resorbing cell. They are in House-Schiff's lacunae. They are in a lacunae which is called as the House-Schiff's lacunae. So you can see clearly the ruffle border here, the multinucleated cells, and you can see they have a foamy cytoplasm. Lining cells, once osteoblasts have completed the function, they are either entrapped in the bone matrix and become osteocytes, or they remain on the surface as the lining cell. Now bone remodeling basically is formation and resorption of bone. Replacement of old bone with new one is called as the bone turnover. The process by which the overall size and shape of the bone is established is called as remodeling. It extends from embryonic bone development to pre-adult period of the bone growth. It occurs as a discrete focal area involving a group of cells which are called as bone remodeling units. Resorption of pre-existing extracellular matrix, the osteoclast, is followed by osteoblastic secretion of extracellular matrix that is well mineralized. And this matrix is also in rhythmic procession. These are called as cemental lines, or they are called as the resting lines. Whereas the other lines which is formed by the resorption base are called as the reversal lines. So reversal lines are basically basophilic. They have high content of glycoproteins and proteoglycans. They mark the limit of bone erosion prior to the formation of osteon, and therefore they are known as reversal lines because they are marking the limit of bone erosion prior to the formation of the new bone. Highly regular, it is formed by the scalloped outline of the House-Schiff's lacunae. The distinct line is stained in sections of bone that indicates the location where bone resorption gave way to bone apposition. The distinction between bone resorption and bone apposition. Different methods you can study the bone, ground section, decalcified section. You can see very clearly here the decalcified section and the ground section of the bone. And special stains can be used specially to see the canaliculi modified Holmes impregnation. Pictothelium stain can be used for this purpose. Clinical significance is basically used in orthodontic tooth movement of the teeth, where bone is resorbed on the side of pressure. Wherever pressure is created, the bone starts resorbing on that side. On the opposite side, you have the bone formation on the side of the tension. You have decreased bone of alveolar processes is noted when there is inactivity of the tooth that does not have an antagonist. Antagonist basically an opposite tooth. Clinical considerations, various disease conditions, you have bone may fail like osteomalacia, where you have deficiency of vitamin D, etc. So we're not going to go into these details, but orthodontic tooth movement, healing of extraction socket, periodontal disease, alveolar bone resorption, and synthetic bone grafts.